Okay, in the interest of time, I think we'll go ahead and get started. I know there's some people wandering in, but since I have the first talk, they won't miss much. Dr. Vizel, my partner, and I will be moderating this session, and I'll go ahead and get it kicked off. And the title of the first talk is Beyond Danger Shock. And so let me hit my start button. For the other speakers in the session, we did a poor job of allowing you timing. We will have a timer down here just to help people stay on time in their presentations. So with that, this is a slide that Bill O'Neill likes to show. 30-day survival rates, 2 decades of trials in cardiogenic shock. And it's really striking. If you go back to the shock trial in 1999, the survival in the revascularization arm at 30 days was 53%. And I'll remind you that that trial was only positive at the 6-month mark. The 30-day mark, there was no difference in survival between revasc and medical therapy. But nonetheless, 53% 30-day survival. Dial forward to 2017, what we think of as pretty contemporary medicine. And in the culprit-only arm, 30-day survival was 54%. So not very far in 20 years. And then we got a hint of promise in what's not a randomized trial, but the NCSI registry, Bill O'Neill and Barbara Basir. All of a sudden we saw 68% survival with the use of the Impella device in MI and cardiogenic shock. So a hint of the future in that registry. And the big news 2 years ago, just about this time, was the Danger Shock trial. So this was a randomized trial, acute MI, cardiogenic shock, lactate above 3, Impella versus standard therapy. And really for the first time in history, we had an intervention that showed statistically positive improvement in survival in a randomized trial. At that 6-month mark, there was a 26% reduction in all-cause mortality that was statistically significant. And if you take it out to a number of years, because this trial enrolled over a long time, they published this really the same year, but they looked at the 10-year data, and that survival advantage was maintained out to 10 years, which leads to the recent update in our guidelines with a Class 2A recommendation to use the microaxial flow pump for patients with STEMI and cardiogenic shock. So really what I wanted to talk for a few minutes about today is how can we beat danger shock? I don't want to just achieve danger shock results. How can we improve on that and do even better than danger shock? And I think these are the points that I wanted to touch on. And many of these things have already been mentioned in talks earlier, and we may scoot past some of these things quickly. But systems of care, teams of care, time is still important, focusing on complications, physiology and hemodynamic monitoring, timely escalation when needed, and as Dr. Hernandez pointed out, avenues to post-hospital care. So I've loved this slide, but it really epitomizes what I think this space is about. These 4 services, interventionalists, intensivists, heart failure shock cardiologists, and cardiac surgery, just really need to come together. And there's a lot we've done here at this institution over the last 3 years, but if there's anything that I'm proud of our team for, it's really coming together in this way. And this happens every day on our units, surgeons and cardiologists and the intensivists rounding together. And that's what it takes to make this space goes. There's a lot of data behind that concept. These have been shown many times at meetings. On the left-hand side of the slide, these are single-center experiences comparing pre-results before forming a formalized shock team versus afterward, showing that at least in that non-randomized fashion, shock teams make a difference. The data on the right-hand side is from a national critical care network, and again showed statistically significant improvement in survival when you bring systems of care, not just unidisciplinary care. So another bullet point there was time still matters. This is data from Danger Shock, looking at stratification based on time to treatment. And you can see in that green upper line, that's the survival of MI with cardiogenic shock when we get people on support within 2 hours of symptom onset. And their survival in that group approaches 80%. So there's a lot of work to be done, and this is a lot of, as Dr. Murley mentioned, there's a lot of pre-hospital education to get people here. So that time to treatment is both out of the hospital and in the hospital. So a lot of work to be done. Time still matters. I just put up one slide. This remains an issue of debate. We don't have a randomized trial comparing Impella pre-PCI to Impella post-PCI, but there's a lot of retrospective data. This is from Babar Basir, stratifying the NCSI registry, and I could show you about 4 other slides that Bill O'Neill has offered for us from different data sets. But there's a fair body of retrospective data to suggesting that survival is better if we get people on pump first and revascularize second. There's certainly exceptions, and patients don't all fit in a neat box, but by and large, the data supports that conjecture. So what have we done here to promote that? This is just a quadrant of our acute MI shock protocol, but we really took this bull by the horns. And so what you can see here is in our system, the ER doctor recognizes MI, recognizes shock, and so the page to the operator is, I've got a patient with a STEMI, and the operator says, with or without shock. And if the answer is with shock, that whole upper quadrant gets notified at the same time. So we have some of our Impella reps here. They get the call at the same time as the interventionalist. The in-house echocardiographer gets the call at the same time. The cath lab team coming in gets a page that says, am I with a shock? And so all those people come together and hit the lab at about the same time the patient does. The table is already thrown. And so those are unique things that I think we've done to try and meet that time still matters, that door to unload time concept. So time is still important. Time is muscle. Complications are key. Others have already mentioned this. There was a price to pay for the survival benefit and danger. Very high rate of bleeding, significant ischemic complications, and a very high rate of renal replacement therapy. So it's all about access and mitigating ischemia. You can see this as a standard antegrade sheath. Somebody already showed a slide like this. This is somebody who went on to ECPella and complex algorithms to maintain perfusion. So it's about ischemia, it's about good access, preventing ischemia, and preventing bleeding. This is really the central role. Dr. Hernandez already showed this slide. The model of an interventional cardiologist does a case and then goes off to the office or is in the cath lab the rest of the day, and nobody's minding the shop, just doesn't work in this space. So it's just critically important that we have intensivists like Dr. Benyassi's group and others who really can monitor all of these systems, assessing hemodynamics, lactate levels, plasma-free hemoglobin, et cetera. So critical care is essential to make this happen. I promised Dr. Earhart, wherever she is, that I'd share this slide. What would Sir William Osler have said about managing shock patients and what's critical to doing it well? I've loved this quote for decades. Sir William Osler said, "A physician without physiology flounders along aimlessly, never able to gain an accurate conception, practicing a sort of pop gun pharmacy, hitting now the malady and again the patient, he himself not knowing which." So physiology and understanding physiology is key to manage these patients. And really that boils down to hemodynamics. Dr. Hernandez already showed this slide as well. This is looking at outcomes in a shock population, whether or not the patients had comprehensive hemodynamic profiling. So this is not just having a SWAN, but having more advanced hemodynamics. The slide on the right highlights the much lower mortality when comprehensive hemodynamic profiling is present. This is how we've done that at our institution. So the providers, it all comes together on one page. So this print is very small, but in that brown up there is the Impella, pump flows and speeds. In the middle is standard hemodynamics. The next line is critical laboratories. And if you could read that top line in the green section, it's lactate, and you can see us tracking the lactate. This is one of our OASIS acute MI patients. Came upstairs with a lactate of 9, and over the next several hours drifts down to 1.4. And on the same page, you see all of the drip rates. So just to highlight the central role of lactate increasingly important and lots of data to support it. So on the left-hand side, that's the rate of lactate clearance. You can see that patients supported with a pump cleared their lactate much more quickly. And in the lower right-hand corner, you can see the impact of that in terms of survival by how fast we cleared lactate. So that's not randomized data, but clearly showing the quicker we clear lactate, the better the patients do. This is similar data from ACC from just a few weeks ago. If the lactate was cleared to under 2 in the first 24 hours, mortality was lower by 20%. Heart failure admissions were lower dialysis. So SKY has really launched an initiative focusing on the importance of lactate. So they're talking about door-to-lactate clearance as a quality measure. But in the first paragraph of this paper, I just quote here a couple of things. It says, "It has become clear that focusing on tissue perfusion is the best early marker of ensuing survival, and hemodynamics per se do not consistently relate to tissue perfusion." So again, it's not just about the cardiac output, it's about lactate as a marker for perfusion. We've talked a lot about escalation. It's one thing to put in the pump, but the CP just isn't enough for some of these patients. And if we delay days, then they're going to do poorly. So recognizing the need for escalation, and when escalation is needed, not saying we'll do that tomorrow or the next day, but doing it in a timely fashion. I won't focus on these survival curves, but I just put this up there to mention that in danger shock, it was about 15% that needed escalation. And I'll say in our experience, we've looked at that number, and it's more like 25% of people end up needing escalation, either to 5.5 or ECMO in our post-MI shock population. I'll jump past this slide. And so the other thing, if escalation is needed, it's important that we have an algorithmic approach focusing on what needs support, RV, LV, and importantly, bringing the right pump to the right patient at the right time is critically important, and we need to have algorithmic ways of thinking about that. And as we already highlighted in the first session, if we're at an institution where not all of these tools are available, then we need to have partnerships. And again, I'm just so grateful for Dr. Murley presenting that case, highlighting the cooperation between centers. Probably one of the places that's done that best and most widely published is Inova, and this is their data of their networking. And what's amazing is those orange and blue bars are survival rates and complication rates for patients who required escalation, whether they were in a spoke hospital or a hub hospital. And so what they're demonstrating here is that given their relationships, given their protocols and algorithms that they've put together with these different systems that surround them, the outcomes are almost equally as good if you needed escalation, whether you started at the spoke or whether you start at the hub. So that's what we really need to try to achieve so that patients regionally, not just patients who walk in the front door of St. Francis, can get the same outcomes. And then lastly, sort of a glimpse of the future. We've come a long ways, but there's amazing things coming. So there's a whole family, and many of you are aware of these devices coming, lower profile pumps that deliver higher flow rates. So the promise, the hope for these devices, still not delivered upon, but the hope and promise of these devices is less bleeding, less ischemia, limb ischemia, less hemolysis, and higher flow rates, and therefore less need to escalate to surgically implanted devices or ECMO. So this is the Impella ECP device from our Abiomed sponsors here today. And so that device is around the corner, a 9-front sheath that'll deliver flows like the CP or maybe a little bit better. So imagine having the CP with a 9-front sheath. The bleeding complications and ischemia should be much lower. So CP-like flows through a 9-front sheath. And then there are a family of devices from many different companies with much larger expandable pumps going through small sheaths. So this is the Magenta device that goes up, and you can see in that slide that the device crosses the aortic valve on a very small profile, but then is expanded to allow pumping. So this delivers 5-like flows through a 10-front sheath. This should play a little bit. You can see how this is a collapsible device. You can see it collapsing there. and it's released. This is the device being retrieved. So pull back across the valve, and I won't let that run all the way. So again, on the right-hand side, you see that's an Impella 5.5. On the left-hand side, that's the closure of a 10 French sheath from a Magenta. So still to be proven, trials still in place, but holds a great deal of promise for the future of managing MI shock patients. I'll skip a couple of those. And then again, this focuses on what Dr. Hernandez already mentioned, the importance of having pathways of care once these people leave the hospital. This is NCDR data for survivors of MI with shock. 10% mortality in the first 30 days after leaving the hospital. 22% mortality at 1 year, high rates of hospitalization. We need to improve on that, and it just highlights, as Dr. Hernandez said, the importance of getting these people to a comprehensive heart failure program, laser focus on GDMT, all sorts of devices and tools we have in our hands, and the promise of monitoring and surveilling them so that if they go on to need heart replacement therapies, they can be offered. And so that's all I have, and I'll stop right there. Thank you very much. And our next speaker is Dr. Keraton, who's an interventionalist joining us from Temple, Texas. I'll let you restart that.
Okay.
Oh, I set my own timer. Wonderful. Well, thank you for having me here today. Pleasure to be here. When Dr. Hernandez asked me to come here and give this talk, it was exciting for several reasons. And I'm going to reveal my true colors here in just a second. But I'm glad Dr. Ensley did talk about the concept of team sports, because I am from Missouri. And one of the exciting things about coming up here was that I looked at a map and I saw that Kansas City Chiefs Kingdom extended into North Oklahoma. So one of the things I was trying to figure out when I was flying over here is whether I would still be in Cowboys territory or if I'd be in Kansas City territory. And so one of the first things I saw when I arrived at the hotel lobby, somebody wearing a Chiefs hat. So I'm going to go ahead and make an assumption that there's a lot of Chiefs fans here. I might get booed off the stage. I might have to have this presentation end early. But this was one of the exciting reasons, but of course learning from the health system here and the wondering and seeing the growth that you have all had here under Dr. Hernandez's and everyone else's leadership is fantastic. I am not an interventional cardiologist, to be very clear. I work in tandem with interventionists. I'm a heart failure specialist, originally from Missouri and now in Baylor Scott and White Health System. But the cath lab is becoming an increasingly important arena when it comes to the management of non-AMI cardiogenic shock, like we've seen across the spectrum of ICUs in our country. Our ICUs are increasingly occupied by non-AMI cardiogenic shock, and in parallel, our cath labs are becoming the battleground for a lot of structural therapies outside of coronary interventions. Again, very excited to be here today. My objectives for the next couple of minutes will be to really describe this unique subset of patients with VHD cardiogenic shock. I will try and outline some support strategies, medical therapies, and how we treat this vulnerable population where their valvular heart disease is driving the physiology of their shock state, with a focus on particular valve subtypes. And we will highlight the importance along the way of the multidisciplinary shock team like many before me have done. So again, not surprising, we live in a very fragmented healthcare system. Patients are seen, they're lost to follow-up, they have moderate valvular heart disease, stenosis, regurgitation. We see those patients, they come in a state of shock, in a state of extremis, many years down the road after having lost their insurance, being lost to follow-up, and we're left with the fragmentation and the disaster that follows. But of course, we also have patients that have very good follow-up and unfortunately succumb to degenerative valve disease at a young age. A mentor of mine when I was a fellow told me very clearly, multiple times, prosthetic valves are a disease of their own. They have a timetable. It's a matter of time until many of those valves degenerate. And that's something that we have to be very mindful of as we follow these patients, whether they have prosthetic tissue or mechanical valves. And then, of course, we also have the IV drug use epidemic across our country, which contributes to some of the other valve-related pathologies that we're seeing. So altogether, in combination with the increasingly comorbid and aging population, this is a very challenging time to manage these patients. Dr. Hernandez and his group, the cardiogenic shock working group, have really shed light on a lot of important data, and the journey for patients with cardiogenic shock often comes down to the first 6 hours, where a lot of these patients switch their SCAI stages very quickly and ultimately in a very short period of time that determines their long-term trajectory. Valvular heart disease is no exception. Arguably, in a much shorter period of time, these patients will escalate to a very high SCAI classification, in part because their valvular heart disease is just as much, if not more so, driving the hemodynamics of their cardiogenic shock state. And some general considerations that we have to keep in mind as we treat patients with valvular heart disease cardiogenic shock is that this is a very vulnerable, understudied population, where a lot of the evidence that we have is derived from observational cohorts from registries such as the STS-TVT registry. Severe valvular heart disease presents unique challenges for the delivering of temporary mechanical support, and the role for many of these strategies in this vulnerable subtype is very much unclear or not well defined, I would say, based on the lack of randomized trials. The primary hemodynamic goals, however, for managing these patients are very much the same. We want to maintain or restore organ perfusion using pressors, inotropes to an extent, but more importantly, in some cases, temporary mechanical support. We want to also understand and recognize that there has been a significant evolution of transcatheter therapies, where now many of our structural heart doctors or interventionists are able to deliver transcatheter valves, MitraClips, which can stabilize these patients in a significant way as a bridge either to definitive therapy or recovery. So to better understand this patient population, we look to registries. So this is an example of really some of the most common etiologies of cardiogenic shock. And not surprisingly, when you look at the spectrum of patients with long-standing heart failure, valvular heart disease as a primary etiology has traditionally been a smaller subset of that population. And again, when it comes to cardiogenic shock presentations, you will see across the board in observational registries or studies such as the DOREMI study looking at dobutamine versus milrinone, looking at the cardiogenic shock work group, looking at the national inpatient sample. A very small proportion of those patients have valvular heart disease as a primary causative etiology for their shock state. But those patients are not only unique, they're unique in the way that they present, in the setting that they behave in many ways similarly to patients that have constriction shock, that have myocarditis, infiltration shock. They may have a normal or a low normal ejection fraction, which really makes it very clear to us that it's not always about the ejection fraction, especially in patients that do not have a history of long-standing heart failure with reduced EF. And when we look at the patients across registries, this being the CCCTN, which is basically an investigator-initiated registry across the US and the UK, level 1 ICUs, we can clearly appreciate that of a little over 5,000 patients that are cared for under these ICUs, the significant proportion of those patients do not have valvular heart disease as a primary cause of their shock state, and yet, of the 4% of patients on the far left-hand side of the screen, the majority of the valve subtypes that we're encountering are mitral regurgitation, or aortic stenosis is a primary or dominant causative etiology of their shock state. These patients tend to be older, they tend to be female, they actually don't tend to have a statistically higher likelihood of having a history of heart failure, and yet those patients have higher SOFA scores, which is a critical care level end organ perfusion metric for illness, than patients that have cardiogenic shock with non-causative valvular heart disease. As part of the journey that these patients have through the cardiac ICU, we learned that a significant proportion of patients that do have valvular heart disease as an etiology of their shock state do not have any valve procedure performed. Of those that do, 18% do undergo surgical repair or replacement, and of the remainder, they can undergo other types of valvular procedures, structural procedures, including balloon valvuloplasty, TEER, and TAVR. And we also recognize that those patients with cardiogenic shock as a valvular heart disease primary mechanism outlined in red are much more likely to have mechanical ventilation. Interestingly, and but not surprisingly, less likely to have mechanical circulatory support systems deployed and less likely to have pulmonary artery catheterization performed compared to the other cohorts. But ultimately, the crude, adjusted, and unadjusted mortality for these patients, both inpatient mortality as long-term mortality, is significant. Significant and much worse than their colleagues. And we see that when we look at the inpatient mortality of patients with cardiogenic shock attributed to valvular heart disease, it is high. It is very, very high. So let's talk through some of these valvular heart disease subtypes. We have aortic stenosis with cardiogenic shock, very dramatic in the ways in which these patients can present, very high inpatient mortality. And there is an increasing role for bridging balloon valvuloplasty or direct TAVR in these patient populations as a bridge to potential future SAVR or as a bridge to definitive therapy with prosthetic valve with TAVR. We have distinct phenotypes that sometimes dictate their acute management. When I was a resident at WashU, we often had quoted to us this seminal study from the East Coast looking at the use of vasodilators to unload, so to speak, patients with severe aortic stenosis that are decompensated, but with the caveat that there are phenotypes of patients that have a lower SVR and low cardiovascular reserve that may ultimately not do well with those types of therapies, in which case we have to focus on pressor support and in very specific cases certain types of mechanical circulatory support. But ultimately a very unique population and a population that we're increasingly seeing. So looking at the data, so again, what data do we have for these types of patients? We look to registries. So the TVT registry looked at this patient population, patients with aortic stenosis presenting with cardiogenic shock, and in this situation looking at those patients undergoing SAPIEN 3 Ultra valve implants. The mean STS score across that population cohort was 10, a little over 10, very high risk from a surgical perspective. And so what we saw is that when patients underwent TAVR with AS cardiogenic shock, there was a 98% procedural success, 98 procedural success. And the factors from both short and long-term mortality that predicted their outcomes were very common sense. Patients on dialysis, patients with peripheral arterial disease, patients that were older, patients with baseline NYHA class 3 to 4. These are the patient subtypes that we have to be more mindful of that did tend to have higher short and long-term mortality. And when we looked at those patient populations at 1 year using the Kansas City Quality of Life questionnaire to look at their quality of life, when compared to those patients that did not have cardiogenic shock but did have aortic stenosis that underwent therapy, there was very comparative outcomes as far as quality of life in patients that did undergo successful transcatheter valve therapy. And the patients and the ways in which they were managed as a bridge to transcatheter therapy were often bridged with inotropes, balloon pumps, and in very select cases, interestingly, catheter-based assist devices. So this is a case example from one of our affiliate institutions. We had a 72-year-old gentleman, a history of ischemic cardiomyopathy and ejection fraction of 30-35%, end-stage renal disease on dialysis, already a higher risk substrate, had underlying coronary disease, and unfortunately a history of active osteomyelitis of the lower extremity on antibiotics. He presented with decompensation with very low flow, low gradient severe aortic stenosis, unfortunately experienced an in-hospital cardiac arrest, positive lactic acidemia, easily SCI-C on D, with high levels of pressor support. After multidisciplinary discussions with our shock team, he underwent bridging balloon aortic valvuloplasty to TAVR therapy. On day 2 of his hospitalization, he underwent valvuloplasty. You can see the pre versus the post gradients, a reasonable outcome, and due to his active osteomyelitis, there was a decision made to bridge him to TAVR 5 to 6 months down the road, and he did undergo successful TAVR implantation and is doing quite well, still alive. This was done in 2024, so still alive 2 years later and doing reasonably well per the interventionist I spoke with. Now, aortic regurgitation is comparatively much lower in prevalence when we see AI cardiogenic shock, but we are seeing it much more increasingly so in patients with failed degenerative prosthetic valves. Again, another point to make about how prosthetic valves, in a way, have their own timetable, and we have to be very mindful of these patients. Now, beyond everything that we know about how we manage these patients medically as far as the withholding of beta blockers, the occasional role for pacemaker implantation, short-term to augment or to affect their diastolic filling time, there is a role for pressors, levophed, epinephrine, diuretics to compensate these patients, but unfortunately these are very high-risk patients, and SAVR up until now has been the gold standard to how we can definitively manage these patients. But we are now in an increasingly interesting era where TAVR systems are being studied, including the JenaValve Trilogy valve, to see if we can urgently treat these patients in a non-operative setting as a bridge to definitive SAVR or long-term TAVR. The traditional issue with TAVR valves has been the relative lack of calcification in the aortic valve system, which is one of the reasons that TAVR has been successful in patients with severe calcific degenerative valve disease. And so we are starting to see an off-label use of TAVR valves in the select patient population. But in other interesting patient population that I think are worth mentioning, especially here in this health system that is becoming increasingly comfortable with committing to durable ventricular support with LVAD, is that patients that have durable VADs, a significant proportion of those patients after several years will develop clinically meaningful aortic regurgitation. And the main mechanism in which we often can treat that is through the use of transcatheter valve therapies. And so this is another case example from a patient at our institution who underwent LVAD and within 6 to 12 months, closer to 12 months, started to experience clinically significant aortic valvular regurgitation, presented, unfortunately, with biventricular failure, multi-organ failure in the context of moderate to severe AI, transaminitis, cardiorenal injury, and biventricular filling pressures. After multidisciplinary case discussion, our interventionist did perform transcatheter valve implantation with subsequent improvement in his hemodynamics and significant clinical recovery, and he is doing well, comfortably much better to this day. From the perspective of mitral regurgitation, this is my last case example, the prevalence of MR is growing. We have afterload reduction strategies with, again, a lot of what we are familiar with, inotropic support, the use of temporary mechanical support systems to unload that left ventricle, to unload that mitral valve. And again, SAVR had traditionally been the gold standard for therapy, but increasingly so in the last several years, we have seen randomized controlled trials that have definitively shown that patients with both primary and non-primary secondary mechanisms of mitral regurgitation can undergo transcatheter mitral therapies with MitraClip as a bridge to recovery. And this is, again, data from observational registries from our TVT registry that defined successful and TEER candidates as patients that had cardiogenic shock at baseline, inotrope dependence, the use of a mechanical circulatory support system, and then define success as what you can see here with an improvement in the MR grade to moderate 2+, or a final MR reduction of greater than or equal to 1 absolute grade. With that definition criteria, they had close to about 86% success rate. So again, very high success rate in patients that presented with mitral regurgitation is the primary dominant etiology of their cardiogenic shock. These patients overall were not significantly statistically different when looking at device failure versus success, except those with success had slightly lower ejection fractions on average. And what they saw is that at 12 months, a substantial majority of those patients continued to have very minimal mitral regurgitation after TEER therapy. And again, using that definition of device success, 86%, 1-year clinical outcomes, very good and sustained. This last case example, a patient that we had recently at one of our affiliate sites, 74-year-old with ischemic cardiomyopathy, presented with what was clinically diagnosed as an NSTEMI with acute respiratory insufficiency. He underwent catheterization, which demonstrated an occlusion of one of his grafts, and unfortunately, he did have some residual obstructive disease in the circ and OM that underwent PCI. He did experience a cardiac arrest on the cath table and had to be urgently intubated. Subsequently, an Impella CP was placed. Pressors were rapidly de-escalated, and this patient was deemed to be recoverable, and the Impella support system was de-escalated and removed. Within 24 to 48 hours, he had an abrupt worsening of his hemodynamic status. Pressors were re-escalated, and a repeat interrogation of his mitral valve demonstrated what was felt initially to be more mild or moderate disease, with actually severe mitral regurgitation as the primary driver of his original presentation. This was felt to be primarily a functional mechanism. He underwent urgent placement of a subclavian balloon pump, and he was bridged to successful TEER with a Pascal device. Since then, he has been de-escalated off balloon pump support, off inotrope soft pressors, with cardiorenal recovery, and is shortly to discharge to a rehabilitation center. The big picture view, again, to emphasize that we have a lot of toys, a lot of tools in which we can manage patients with valvular heart disease, cardiogenic shock. We have to tailor those types of devices to the patient with the understanding that with valvular heart disease, there are some additional caveats that we have to keep in mind, certain devices that cannot be used in patients that have certain phenotypes of valvular heart disease. In conclusion, there's been a continued growth in the population of valvular heart disease. We know this, we're seeing this, we're feeling this in our ICUs. I hope that any interventionists here have been and will be empowered to be a more active part of their multidisciplinary team to be able to help bridge these very sick, vulnerable patients to definitive therapy or to recovery. But valvular heart disease is a very quintessential example of shock with what can be, quote, a normal/low normal ejection fraction. Multidisciplinary teams are essential, and future data on optimal patient selection for valve procedures is needed. Thank you.
Thank you very much, Dr. Carradine. I apologize for misclassifying you with the rowdy bunch of people who call themselves interventionists.
Great.
Our next speaker will be Dr. Orrin Friedman, who joins us from Providence Holy Cross Medical Center in LA to speak to us about obstructive shock in the setting of pulmonary embolus.
Thank you so much. It's really a pleasure to be here at your very beautiful facility here. It's fantastic. This is the topic I'm going to be speaking about today. So first I want to start off with the fact that PE is the third leading cause of cardiovascular death. And I'll let that sink in for a little bit. So it trails behind coronary disease, stroke, and here we are over here as number 3. And when you think about the attention that's spent in terms of MI, stroke protocols, and compare that to the amount of attention that's spent in PE, it's really not a comparison, right? So you can go to any hospital across the country, everybody has a STEMI protocol, everybody has a code stroke protocol, but yet somebody can walk into the emergency room with a large pulmonary embolism and it can be really chaos in terms of how they're treated. Share a lot of the similarities between these diseases, right? They're all thrombotic cardiovascular related diseases. And in thinking about this mortality, I'm going to ask a question, which is, how do people actually die of pulmonary embolism? Let's sort of think about that for a second. Because is it end organ damage? Is it end organ ischemia the way it is for a brain and for an MI? Are we talking about pulmonary infarct as really the problem we're dealing with? Do people die of respiratory failure from PE? And the answer is really no. That's very, very rare. Really, what it is it's more of like a pre-organ failure. I kind of made that term up, but you know what I mean, right? So it's the pulmonary embolism creates an afterload and creates pressure back on that right ventricle, causing that right ventricle to fail. So truly, at its core, and pun very much intended here, at its core, PE is really a right heart disease. I think by the end of this talk, if I can convince the cardiologists that you guys should own this disease, I'm going to say that there is success. But really, what's a pulmonary embolism is truly an acute right heart disease. So an extraordinary thing happened just last month. A bipartisan bill was passed, so to speak. An executive committee, Senate, and the House of Representatives, and that's the pulmonary groups, the cardiology groups got together, and the interventional radiology groups. You guys can decide which one's executive and Senate and the House. We can debate that afterwards. But this almost never happens, and they got together, they totally redid all the pulmonary embolism guidelines. So obviously I don't have time to get into that, but basically they split it up from what we used to call as low risk, intermediate risk, and high risk, and now we have these B, C, D, E categories. I can definitely see the cardiology influence because there's a lot of overlap between SCAI here and SCAI shock stages. So we're going to focus on D and E here. So E is now what we call a pulmonary embolism that's presenting in shock. D is what they call kind of a pre-shock state or a hypoperfused state, and those are even further split down into further granulation, where D1 is sort of transiently hypotensive. D2 are people, folks who have markers of end organ hypoperfusion, including lactate and acute kidney injury. You can see over there in the E world, we have E1, which are folks who are basically on maybe about one vasopressor. We have E2, which is more similar to like a SCAI shock D stage, where you're on multiple vasopressors, all the way up into cardiac arrest. But what's nice about having a D stage, we never had anything like this before, is a recognition that a lot of patients who are normotensive may truly be in a hypoperfused state. And this was really an excellent trial that came out of NYU in which they looked at patients who we otherwise would have called intermediate risk PE. They were normotensive, but they had RV dysfunction. And these are folks that were going for mechanical thrombectomy of their PE. Pre doing the mechanical thrombectomy, they did a quick right heart cath and measured the cardiac index. And up to almost half of them had a cardiac index less than 2.2. So this was pretty striking in the PE world. I think it opened a lot of people's eyes. We began calling this normotensive shock or subclinical shock. But people would be otherwise quite concerned, I would say, about having a cardiac index less than 2.2. So a lot of these patients might be sicker than they may appear. And I love Dr. Ensley's reference to William Osler. So this one's for William Osler. And this is a little discussion of why that shock happens and why that sometimes happens before you even form hypotension. And if you imagine that the right ventricle is like a pressure volume circuit in a very simple way, here where you have stroke volume ejecting on the top, you have diastole on the bottom, you have isovolumetric contraction on the right side and relaxation on the left-hand side. You can see that we call the ventricular elastance, which is the pumping function of the heart. And as we relate that pressure to its volume, so the pressure changes over its volume, that's known as the elastance. And that's sort of an intrinsic marker of how strong your right ventricle is. This end systolic pressure volume relationship really holds steady across many different loading conditions. On the other hand, that's injecting into another pressure circuit, the arterial circuit, right? So the pressure as it relates to the stroke volume, or the delta P, or the pulse pressure as it relates to the stroke volume, is the arterial elastance. And you can see as that arterial elastance increases, such as what happens when you have a pulmonary embolism, the stroke volume is naturally gonna fall. It's just physics. It's just the way that things work. Unless that ventricle is able to improve its elastance and meet that increased demand, increasing the stroke volume and sort of recoupling the system or rebalancing the system. When the system's in balance, we call that a coupled system or balanced system. When the system's unbalanced, that's what we mean when we say the system is uncoupled. And frequently, with acute pulmonary embolism, we're over here. We're on this uncoupling side. And the fact is that right ventricle has a very difficult time meeting those increase in those loading conditions, and frequently we fall into that uncoupled situation. Why does that happen? Well, we know that famously the right ventricle is very sensitive to afterload. It's much more sensitive to afterload than the left ventricle for a variety of different reasons, but not the least being the fact that it's a thin-walled structure. It's tubular. It is meant and designed to accommodate large fluctuations in systemic venous return and pump that venous return into a very low impedance, low resistance circuit. It's simply not designed to meet an acute afterload condition. And when it does, the stroke volume tends to fall, and it tends to start a cascade of worsening hemodynamic instability. We can predict this happening on echo. So when we look at the RVOT VTI, right, which is the flow across the outflow tract from the right ventricle, the VTI correlates with the stroke volume. And this was another excellent study out of the NYU group in which they looked at patients with pulmonary embolism who had a low RVOT VTI. And perhaps not surprisingly, that was an excellent marker for predicting the patients that ended up having subsequent hemodynamic deterioration and subsequent death. In fact, better than many of the other markers that we have for predicting how people are going to do with pulmonary embolism. It just makes sense because it really gets to the physiology behind why people decompensate with PE. So another important physiologic caveat here has to do with coronary perfusion. And under normal physiology, the aortic pressure always is on top of the pulmonary artery pressure. There's always a delta. There's always a gradient there. And with that gradient, the right ventricle, turns out that there's coronary perfusion in both systole and diastole. That differs from the left side. The left side's only perfused in diastole because of the perfusion gradients. However, when you start having an increased afterload and the PA pressures rise, the RV perfusion starts to look a lot like the LV, and it begins having a biphasic distribution. It's only perfusing in diastole, so it loses a significant amount of coronary perfusion. Our RCA and the left-sided coronary arteries don't have the same autoregulation. So the left-sided coronary arteries are able to autoregulate over a wider span of this perfusion gradient, whereas the right side, as you can see on the bottom, looks a lot more linear. So as that perfusion gradient begins to fall, as the PA pressures increase, as the systemic blood pressure drops, that coronary perfusion goes down and you begin getting ischemia. And ischemia is a really important part of how pulmonary embolism patients tend to start doing very, very poorly. Now, the right ventricle, as I mentioned, is very, very thin. So when the right ventricle gets ischemic, you get transmural ischemia. Right? Left ventricle is a little bit more resilient. It's thicker, so the ischemia is really subendocardial. And when you look at what happens here as the ventricle gets ischemic, as the RV cardiac output falls, the left-sided cardiac output must fall because the two ventricles are linked in series. The left ventricle can't pump out any more than the right ventricle delivers it, so the left ventricular cardiac output must fall. However, they're also linked in parallel. And what we mean by that is because they share the interventricular septum, as the RV begins to fail, begins to dilate, that interventricular septum begins to bulge into the left ventricle, and you have this famous septal bowing that we see in a lot of our PE patients. And it's a really fascinating concept. It turns out it's a lot more complicated than simply the pressure difference between the right side and the left side. It has to do with things like delayed contraction of the right ventricle, the geometric connection where there's hinge points at the septum that tend to pull on the septum and straighten it. But the real bottom line is it's not just a marker of hypoperfusion or not just a marker of bad physiology. It's actually a geometric maladaptation that worsens the physiology of shock as people develop worsening pulmonary embolism. So here you can see what happens. We have a pressure overloaded situation. We know that that contributes to RV ischemia on the left-hand side. It, of course, eventually leads to a decrease in RV cardiac output. As I mentioned, that has a double mechanism, both in parallel and series, causing a reduction in LV cardiac output. Eventually, you develop systemic hypotension. Once you develop systemic hypotension, the RV ischemia gets really worse. And here's really the key. When you get hypotensive from a PE, it's unleashing an animal. Bad things tend to happen, and those bad things tend to happen very, very quickly. You honestly don't have a lot of time to stabilize these patients. So as I'm getting on to treatment, one of the messages I'd like for everyone to take home is act quickly. If you have a PE patient with hypotension, sustained hypotension, it is going to get worse, and it's going to get worse quickly, because that cycle, remember, is self-perpetuating, and you're going to tumble down that cycle all the way up to cardiac arrest. So first part of the treatment, I know I'm supposed to talk about pressors and stabilization, is you can't talk about that without talking about what are you going to do about the clot. I mean, you have to tackle the PE. You have to tackle the lesion that's actually causing the problem here. And the traditional answer for dealing with this was systemic lysis. So for many, many years, all the guideline recommendations said, class 1 recommendation, you're hypotensive, you get systemic lysis. But we had a lot of problems here, lots of limitations, not the least of which a lot of our PE patients simply have absolute contraindications to getting systemic lysis. It's just not practical, right? You can't give systemic lysis to somebody who just had major surgery. You can't give it to somebody who potentially has a tumor in an area that you're worried they're going to bleed, such as brain, pancreas, liver, that type of thing. Surgical embolectomy is always talked about at conferences, but very rarely done. In many centers, there's not really anyone who's there and able to do a surgical embolectomy on these patients. On the right-hand side, we have ECMO and catheter embolectomy that really didn't come into existence until recently. But in the last 5 years or so, these have really become important, really, really, truly important tools in taking care of our highest risk, our real true Class C pulmonary embolism patients. And that's because the technology has gotten better. We've gotten more used to using ECMO in shock situations. In terms of mechanical thrombectomy, this trial really put things on the map. This is a FLAME trial. It's a very unusual trial because usually there really are not that many trials in the high-risk PE population. But what they did is it's a parallel registry. So these were about 50 patients coming in with PE and shock to various centers across the United States. They looked at those who got large bore mechanical thrombectomy using the Inari FlowTriever device versus just getting standard of care, of which the majority of them got systemic lytics. And they looked at the mortality difference. You can see a very low mortality for PE plus shock in the FlowTriever arm, and then a very standard mortality in the other groups, which is about 28 to 30%. So, our PE in cardiogenic shock is like your STEMI in cardiogenic shock. It's high risk, it's high mortality, you got to act quickly. But I think after this trial, it opened up many people's eyes to say that mechanical thrombectomy is a really important tool to use in this situation. So it's getting very crowded. There's lots of mechanical thrombectomy devices out there. We're sort of in the PE world where maybe the cath lab was around 20 years ago, where there's an explosion in different devices, an explosion in interest in doing catheter therapy. There's been a general movement towards very large bore devices. Why does it have to be large bore? Because we're dealing with big spaces. We're not talking about little coronary arteries, we're not talking about the brain here with the middle cerebral artery. We're talking about 3-centimeter pulmonary arteries. We're talking about folks like this who have clot in transit, large bulky clots on their right atrium. So that requires big devices because you're removing large bulky clots. And when you want to sort of create these surgical samples, that takes devices like you can see there in the middle, large bore mechanical thrombectomy devices that are placed through the femoral vein across the pulmonary artery, and they use suction to be able to sort of suck out this very, very large bulky clot. ECMO is a very, very important tool here. This is a case of a young lady who's 40 years old who had uterine fibroids, who ended up collapsing. On arrival to the emergency room, she had a cardiac arrest, was given the standard systemic treatment, and as sometimes happens, that's not always the most reliable thing. Although she was able to get a pulse back, she remained in severe cardiogenic shock, was cannulated onto VA ECMO, and used that as a bridge to mechanical thrombectomy. So combining these tools together has become very, very important. Stabilize the circulation with ECMO, get them to the cath lab, do mechanical thrombectomy. ECMO, of course, can also be used even in the setting of CPR. If you know that the patient had a cardiac arrest from pulmonary embolism, I'd put that in the category of a fixable, identifiable cause of cardiac arrest, and would be a very good candidate for eCPR, getting them onto ECMO and then getting that clot out of their body. So in terms of my own thought on how we take care of patients with PE, I really got a rush here. I've migrated from using it on everybody with systemic lysis. Everyone gets systemic lysis and only using mechanical thrombectomy on those who meet contraindications, to moving towards ECMO, and mechanical thrombectomy is really being a very standard part of resuscitation. So I'm just going to move on here through some of these echo images to talk just very quickly about the vasopressors, because I do think that this is important. One of the most important goals here in terms of shock management for PE is maintaining your systemic blood pressure. I really can't emphasize that enough. You want to maintain your systemic blood pressure over your pulmonary artery pressure. This is a case of a patient getting CTEPH surgery with very, very high PA pressures, but as long as the systemic pressure is higher than your PA pressure, you preserve coronary perfusion. So the first thing you got to do is you got to reach for a vasopressor. I recommend reaching for norepinephrine. It's reliable, you can get it in, it's very easily titratable, and some of those other vasopressors I'd put more as a second line. Once you've already stabilized the blood pressure, that's when you add in your inotropes. Dobutamine, I think, has the best profile for adding in an acute situation on top of norepinephrine. Although we like milrinone in a lot of our chronic pulmonary hypertension patients, it causes too much hypotension for an acute shock state to typically use for pulmonary embolism. A quick mention about inhaled pulmonary vasodilators. It always makes everything look beautiful. They always work. They always seem to work reliably. It turns out that there probably is a role in acute pulmonary embolism, even though you know that the PA pressure mostly is caused by acute clot. It turns out that a lot of the additional PVR increase is because there's vasoactive mediators released into the pulmonary circulation, and that inhaled nitric oxide can balance that out a little bit and help the circulation. So lastly, I'll just mention this. In many, many shock states, including a lot of the cardiogenic shock states, airway management, intubating patients, getting them on mechanical ventilation is a very important part of shock management. Right? You stabilize the airway, you take away the work of breathing, you put that work of breathing onto the mechanical ventilator. We know that that's really important, especially for people with shock and acidosis. However, with PE, when you intubate a patient, just know this, you have a very, very high likelihood of precipitating cardiac arrest. Right, so your first question should be, does this patient absolutely need to be intubated? If they absolutely need to be intubated, you better be ready to go. This is not easy to do. You need a cardiostable induction with very, very low levels of induction medications. Don't give propofol. We're talking low amounts of etomidate, ketamine. Make sure you have a pre-induction arterial line. I used to say have the vasopressors ready. Forget about having them ready. Just put them on. Just put the patient on vasopressors. You know they're going to drop. I'd rather them go into their intubation a little bit hypertensive and then drop down to normotension than sort of wait to try to catch up. Add the inhaled nitric oxide. If you're going to intubate a PE patient and you're in a center like this that has ECMO, call for ECMO at the same time. I really can't emphasize the likelihood that this patient may have a cardiac arrest, and you really want to be ready to go. And then you have to be mindful of the fact that even once you get the tube in, you can't just sit back and relax, because there's a lot that you have to think about with a mechanical ventilator, because it turns out that if your tidal volumes are too low, your PVR goes up. If your tidal volumes are too high, your PVR goes up. You have to avoid acidosis and hypoxemia. It's a difficult patient to take care of. It requires a lot of diligence, and it really requires normalizing physiology, which goes against almost every other shock state. Right? We usually have minimally acceptable physiology, and we try not to make things normal. When it comes to PE and acute right heart failure, we want to make everything look beautiful. We want to make normoxia. We want to make them to have a normal pH, and that's sort of very different than managing other shock states. So I'm finishing up here, and these are my take-home points. So PE really creates a terrible death spiral. Be aware of that. Recognize the physiology that's driving this. When you have a PE patient that's unstable, think right off the top how I'm going to take care of them, whether it's systemic lysis, it's mechanical thrombectomy, whether it's getting them onto ECMO, or ECMO is a bridge to mechanical thrombectomy. If you're going to treat the shock, recognize, get that blood pressure up first. Use vasopressors. I'm recommending starting off with norepinephrine to stabilize the blood pressure. After you stabilize the blood pressure, that's when you can start adding in things like some inotropes. And lastly, just a real caution to be aware of intubating your PE patients. And with that, I will cede my time.
Thank you very much, Dr. Friedman. Our next speaker is Dr. Hassan, joining us again from the Baylor Scott and White system in Texas. And he's going to speak to us about different pathways related to cardiogenic shock and dilated versus restrictive situations. Thank you.
Thank you, everyone, and thank you for inviting me. This is a pleasure for me to be here. I'll be talking about pathways in heart failure related cardiogenic shock. I'll be focusing mostly on restrictive versus dilated. It is a tough talk to give, but I'll try my best. Again, we have to go back to physiology. We'll start with what is restrictive physiology. Basically, it's a stiffening in the heart that causes ventricular pressure to rise precipitously, slightly exponentially, with only small increases in the volume. And so we see that in many etiologies of heart failure, not just restrictive cardiomyopathies. We see that even with dilated cardiomyopathies, hypertrophic cardiomyopathies, and restrictive cardiomyopathies. In general, the definition of restrictive cardiomyopathy entails a few etiologies, as you can see above here. Non-infiltrative disorders like idiopathic systemic sclerosis, infiltrative disorders like amyloidosis, sarcoidosis, and hereditary hyperoxaluria. Storage diseases like Anderson-Fabry, Pompei's, Gaucher's disease, and others. And finally, endomyocardial disorders like carcinoid. Essentially, going to physiology, you'll see here two PV loops. One is a normal PV loop, and the other is a restrictive cardiomyopathy in shock. So focusing on the right-sided table, you'll see essentially a stiffer heart with a higher end-diastolic pressure because of this EDPVR slope here, as well as in those patients in cardiogenic shock, you'll see a depressed slope of the ESPVR due to decreased inotropy. So theoretically, those patients coming with, let's say, end-stage amyloid or end-stage HCM patients, they have both decreased inotropy and decreased lucitropy, which is the compliance of the left ventricle, but to varying degrees. And so the thought is there's a spectrum of the disease based on both entities together. With inotropes, the goal for those patients is to try to improve the stroke volume by improving the inotropy and the slope of the SPVR, and that improves your stroke volume. Same thing with the balloon pump. We're trying to reduce a little bit your end-diastolic pressures, but at the same time improving stroke volume with the mechanical circulatory support. I'm just going to briefly mention transvalvular pump, but we'll talk about their limitations in restrictive diseases shortly. So this is a good slide to show you the spectrum or the syndrome of cardiogenic shock and restrictive cardiomyopathies. And this is based on the different definitions that we have. For example, on the left side, you see a patient with cardiogenic shock due to restrictive cardiomyopathy from radiation. And on the left side, on the right side, you see an advanced amyloid patient. And the difference is, even though initially the ejection fractions for both perhaps are the same, the mechanical contractility or the myocardial contraction fraction is really reduced in a patient with amyloid versus other etiologies. So that's your initial thought here, that the stroke volume is reduced because the end-diastolic volume or the cavity of the heart is reduced, on top of the stiffness as well as the reduced inotropy. On the left side, more likely those patients are going to go into cardiogenic shock because the main driver is the reduction in the inotropy and the contractility. Again, we went through physiology basically because there's a limited studies out there published on restrictive cardiomyopathy and shock, but I'll be extrapolating some of the data that we have from patients who have gotten transplants, and so we'll look into those together. Over here, we'll start with inotropes. The prior era of transplant adjudication, we used to get patients on inotropes more often. Around 50% of the patients waiting for heart transplant were stabilized on inotropes. In the more current era, this is a little bit less, perhaps more so because we're having more of those patients on intra-aortic balloon pumps. But we do know those patients waiting on the heart transplant list on inotropes have a high risk of mortality. So that's a clear sign that perhaps those patients are at high risk, as we know from arrhythmias during this stage. For intra-aortic balloon pumps, also there is just a scarce data out there. This is one publication from 2023 showing intra-aortic balloon pumps do work in patients with cardiac amyloidosis. As expected, they have better mean arterial pressures, mean PA pressures, wedge pressure, and aortic pressure, as well as improvement in their cardiac output. And this improvement in hemodynamics does sustain over for at least 48 hours follow-up with the balloon pump with improvement in lactates. The nice observation, and this is from the same publication, is that patients who are more responders, who are restrictive cardiomyopathy and shock, who are more responders to the balloon pump, are typically patients having higher SVR and a larger left ventricular end diastolic diameter. So it just makes more sense that there is more filling in the left ventricle, that the balloon pump is able to allow for better stroke volume. Again, this is from the prior publication I hinted to. Balloon pumps currently are more used on waiting lists to stabilize the patients for transplant. Our understanding of left ventricular device implantation in restrictive cardiomyopathy has changed over time. The initial publications back maybe 10, 15 years ago, we had a lot of poor outcomes. This is just a case series published back in 2013 showing high risks of organ failure and infections. And most likely in restrictive cardiomyopathy patients, those patients have higher risk of suction events, low flows, and pump thrombosis, especially with the older generation LVAD pumps. And you would think about this, the main reasons are secondary to the small ventricles, as I discussed, but also biventricular dysfunction, the involvement of amyloid and HCM, for example, with RV dysfunction, and high risk of infections in those patient populations. But ultimately, our understanding has improved with time, and we've realized that those patients, even if they are HCM or restrictive cardiomyopathy, if they have an LV end diastolic diameter that's quite allowing for LVAD or durable LVAD support, then they do fare better than patients with smaller left ventricular end diastolic diameter. This is also another study showing the same findings, and it's published back in 2015 with a cutoff of LVEDD of 4.6 centimeter. Ultimately, dilated cardiomyopathies are easier to LVAD because of the diameter of the left ventricle itself, but those patients who undergo LVAD, who are HCM or RCM patients, do fairly okay, similar to the other population as well. Just as a hint, if you are planning to take care of patients who are amyloid cardiomyopathy, their outcome with an LVAD is different than the other RCM population. They have worse outcome, and most likely this is related to inherent multi-organ dysfunction and systemic disorder as well. Certain centers do place their patients on biventricular support, and this is a study by Kittleson and Kopashigawa, where they showed their case reports of amyloid patients who undergo BiV support as a bridge to transplant, and their outcomes reported here as 82% positive survival. Again, going back to my initial reference here, ECMO outside the mentioned prior article for those patients is around 4.5% as a bridge to transplant. Our experience in our center, we've done a few patients with, this is a case of an AL amyloid patient who's 45 years old, presented with, to us in shock. She was supported with a balloon pump and underwent heart transplant. She's doing fairly well with a very good response for her with her AL treatment. This is another patient with hereditary ATTR, but definitely with a better LV and diastolic diameter, we were able to consider Impella support rather than a balloon pump support, and he was also, during the creation of the slide, he was still waiting transplant, but he is post-transplant right now. And finally, we do have another patient, wild-type TTR, same thing, the LV diameter allows for durable LVAD support, and this patient was ultimately implanted with an LVAD. If we look at the trends of the heart transplant outcomes for those patients, RCM and non-RCM patients are quite similar. But if we want to look at the details of that, the higher mortality cases are still in RCM or in amyloid and in radiation therapy-related subtypes of restrictive cardiomyopathy. However, if you look also at hypertrophic cardiomyopathy, those patients fare better than their counterparts. A few more slides here. I'll talk about the advancements in amyloid treatment, the new era in the green line here. We're doing much better with those patients post-transplant. Okay, the next is just a few slides on dilated cardiomyopathy. I'm not going to talk too much based on the limited time I have, and based on knowing that the next session is going to be all about mechanical support systems. But briefly, idiopathic, we differentiate idiopathic dilated cardiomyopathy, familial, and de novo cases, as well as secondary cases, which include, to a certain extent, some valvular cases, hypertension-induced anthracycline, and other medication-induced dilated cardiomyopathy, as well as other etiologies like alcohol and peripartum cardiomyopathies. Ultimately, because of their dilated left ventricle, they have more options, unlike restrictive and hypertrophic cardiomyopathies, to end up with a durable LVAD and transplant. But if we look at the trends quickly here, ischemic and idiopathic dilated, there isn't too much difference. There isn't difference between the sexes, male and female. And if we look at other etiologies like Adriamycin cardiomyopathy, there's not too much difference in survival. This is another case of presentation of left ventricular non-compaction as well. The only thing I would highlight is alcohol-induced dilated cardiomyopathy do have a reduced outcome post-transplant. And just keep that in mind in your planning for ultimately for those patients. Again, I'm not going to go over the nuances of treating patients medically and mechanically, but ultimately the goal, as we all know, is ventricular unloading and organ perfusion, minimizing complication and decongestion, even in those restrictive cardiomyopathy and dilated cardiomyopathy patients, with ultimately improving their perfusion markers and decongestion markers. And those are the mechanical support systems we will be seeing in the next few hours. Final slide. Not all restrictive cardiomyopathy, cardiogenic shock is born equal. Think about the different definitions we've created. And so a radiation-induced restrictive cardiomyopathy may be dealing with more reduced inotropy and contraction versus the, the small left ventricle stroke volume because of a thickened heart from an advanced cardiac amyloid patient. And same thing, not all dilated cardiomyopathies are born equal. Think about the example of an alcohol-dilated cardiomyopathy. MCS will be talked about, but current transplant listing favors MCS for all eligible patients. Thank you.
Our final speaker in this session is my partner, Horia Feazell. Dr. Feazell is the physician lead for the Whole Heart and Vascular Institute here at St. Francis, and also heads our structural intervention program. He's going to present a case of papillary muscle rupture in the setting of acute MI.
Yeah, so I have the pleasure of being the immediate pre-launch talk, so I'll try to make this quick. But the good news is that I am an interventional cardiologist, so I have no fancy flow volume loops or data or anything like that. It's mostly just pictures, so we'll try to make this pretty smooth here. So our case presentation today starts, this is a patient, 73-year-old woman, pretty healthy. Historically, she does have permanent atrial fibrillation that has been historically rate controlled with oral anticoagulation as well. But otherwise in excellent health, had an echo many years ago prior to this that only showed some mild mitral regurgitation and otherwise preserved LV function. She presented in the evening with a late presentation inferior MI. She had been having chest pain for several days prior to that presentation, had a markedly elevated troponin. Upon arrival, she was found to be in cardiogenic shock. And she was taken immediately to the cath lab. There, she received an Impella CP and a PCI of her RCA, which was successful. An LV angiogram was not performed, but she did receive a Swan-Ganz catheter and a radial art line, and she was transferred to the ICU. Here's her left system, pretty unremarkable as you can tell, pretty much normal. And this is her right. So subtotally occluded mid-right, requiring 3 stents with an excellent final result. So she was transferred to the CCU with an Impella and a Swan-Ganz catheter in place. Subsequent to that, she continued to demonstrate persistent hypotension and rising lactate, pressor support requirements increased. A TE was performed and it showed severe mitral regurgitation, but no clear papillary muscle rupture at this point. Shock team was activated at that time, and the overall impression was that the patient had biventricular failure, and there was a papillary muscle dysfunction, not necessarily rupture. She had respiratory failure, and the patient was placed on VA ECMO with consideration of intervention for her mitral valve if she were to worsen. So she was placed on ECMO within a couple of hours after the shock team activation. Several days later, her oxygenation had improved. Chest X-ray had cleared. She was still requiring MCS, so the decision was made at that time to place an Impella 5.5, and her ECMO was decannulated. Subsequent to that, she developed right ventricular failure, requiring additional RVAD support with a Protect Duo. And during that evaluation, when she had her TE, a ruptured papillary muscle was identified with severe MR. So I'll show, how do I hit play here? Okay, there we go. And as you can see here, here is our just mitral valve and a ruptured papillary muscle. And if we go to the next, here's another picture again. And here is the area in question. There's the papillary muscle just sort of floating around in the left ventricle. And I think, oh yeah, here we go. And here's the consequent mitral regurgitation, which is a very broad jet and very severe. So at this point, the decision was made to consider mitral valve intervention. Patient was worsening from a clinical standpoint, and at this point, she was considered a poor candidate for surgery, which would be the traditional therapy in this setting. So we took her to the cath lab, and she underwent mitral TEER. She got 2 XTW clips, and I think here you can see the valve, and there's a area that is flail with a pretty significant flail gap. We initially, well, actually, did I? No, that's right. Just make sure. Here you can see that here's the 3D image of the mitral valve apparatus, and here we'll show you the first clip. So initially we went in very medial, or a little bit almost to the commissure with an XTW clip, knowing that this was going to be a 2-clip case, more than likely, given the broadness of the jet. And so typically it's much easier to go from medial to lateral. So we placed the first one here medially, got a pretty good result, but you can see there's still pretty significant MR. And here is the second clip, which is essentially right at A2P2, right in the middle of the valve. And we were pretty pleased with this result overall, with a pretty reasonable mitral gradient at this point. And so that's the final. And then post here, about the next day, the patient was able to have her 5.5 removed. And then the day after that, her Protect Duo was removed. She had a prolonged ICU course, respiratory failure, and tracheostomy was placed. But ultimately, she was able to be discharged a little over a month after her initial admission, or I guess 2 months. And this was her pre-discharge echo with relatively preserved LV function and mild residual mitral regurgitation. And this kind of procedure, really, up until we started this whole process down, developing the MCS team and bringing in Dr. Banyasi and sort of formalizing the structure of it under the direction of Dr. Ensley, we weren't able to do procedures like this. And these patients were either dying or they were getting shipped away to other centers. And since that time, we've done probably a couple, 20 or so MCS cases of varying degrees of either aortic valve disease, mitral valve disease, and other structural heart procedures. So this has completely revolutionized our capabilities and expanded our sort of scope. So that's kind of the end of my talk, but that was kind of the story with that patient. Very big success.
We'll do just a couple of questions before we break. I wanted to direct a question to Dr. Kerrigan. Dr. Feazell and I was previously in the structural space, no longer, but several years ago we started seeing reports about mitral tear for cardiogenic shock just across the spectrum. And we've done a handful of cases. This one, we had a patient that was ECMO dependent, wouldn't come off ECMO, had severe MAR. Corey clipped that case as well, and he came off ECMO. But there's just the number of people with cardiogenic shock in the dilated low EF section. Most of them have moderate to severe MAR. Can you talk to us a little bit about your algorithm about when you offer somebody mitral tear in that sort of setting, assuming anatomic feasibility, assuming the mitral valve is clippable, when do you offer mitral tear and when do you not in somebody sitting in unit in cardiogenic shock?
It's a great question. It's a complex question. It's a question that should involve the multidisciplinary team, especially our advanced heart failure team. So having Dr. Hernandez here to be able to be part of this discussion is very helpful, because we really need to take a close look at everything that's gone on with the patient, look at their LV diameters, really just get a good sense of what's truly driving their shock state. If we feel like this is a salvageable patient that will have a reasonable risk or a reasonable chance of recovery, then after reviewing everything from echocardiographic data, reviewing the hemodynamics, then I think really just having that conversation with the understanding that sometimes these patients will do well, and sometimes, despite everything that we're doing, they will continue to struggle and require high levels of mechanical circulatory support. We often do open background evaluations for patients for advanced therapies considerations in the chance that we are unsuccessful and try to offer these therapies but cannot have adequate hemodynamic recovery. So it's a question that is continuing to challenge us, and it was a topic that we discussed at ISHLT recently. There was a great shock consortium on that very issue. How do we deal with patients that are either post-cardiotomy or patients that we're trying to really risk stratify towards these types of structural or operative interventions, and how do we decide which patients are too high risk and which aren't? And unfortunately, there really isn't a good unified algorithm for these cases, but I think looking at these patients' diastolic, left ventricular diastolic dimensions, getting a sense of how dilated they are, is this somebody that's going to truly benefit based on the results of COAP from these types of clips? Is this a disease of the ventricle, or is this at this point more a disease of the valve? Is going to be very helpful and insightful towards making those decisions. But ultimately, it really just comes down to, as always, patient anatomy.
Before you have any comments on that topic? Anything to add?
No, I agree. The timing of intervention is always a very challenging thing, and also what kind of therapies and how the patients will do, not just acutely but long term. Because I think we can do a lot of things and we can get very good acute results, almost always. I mean, even in these acute MR, the registries for acute MR post-MI patients, the acute success rates are over 80%. But then how do you know how those patients are going to do downstream? I think that's largely unknown for a lot. I mean, there's no randomized trials in this space. So hopefully within the next few years we'll have some more data.
One question for Dr. Friedman. It's really sort of the same question in a different space. So our PE shock protocol is in development, but we have preliminary stuff, and we work closely with the MCS team. But what we've talked a lot about is which patient in the lab do you proactively put on support? So we have ECMO on hand and backup, but the question is, where's the dividing line? When do you pull the trigger, ECMO before thrombectomy, or thrombectomy with ECMO in the room backup, or when do you move ahead? Any thoughts about who needs it proactively before you even start?
Yeah, that's a great question. So, the question is when to pull the trigger on ECMO. I think preemptively. I think we know when to do it when someone's obviously in profound shock or somebody's near cardiac arrest, or I'll add, the other situation, which is they are simply just too sick to move to get to the lab. You know that if you're going to move them, they're likely to go into cardiac arrest. Well, then the answer is easy. It's ECMO. I think what you're getting at is a little bit harder. It's, you got someone to the lab, they're borderline. Should you preemptively place them on ECMO in order to bridge them through the procedure? So, my thoughts there probably lie mostly, in looking at the hemodynamics. I mean, it's, what does their heart rate look like? What does their blood pressure look like? How does it relate to their baseline heart rate? And where's the trend? So I think if the trend is, they're 90, they're 100, they're 110, they're 120 in terms of their heart rate, and their blood pressure is slowly dropping, that's a good patient to get, I think, preemptively on ECMO. I think, it's a very reasonable approach, which is to, get sheaths in, be ready to cannulate, and see how well they tolerate the procedure. So I think, typically that first cross into the pulmonary artery with a large bore device is going to tell you a lot of information about how well they're going to tolerate things. So I think it's okay to sort of say, let's give this a shot. Let's try to cross the PA. If they immediately get hypotensive and they get tachycardic, well, then maybe we pull back. We can go on ECMO and then place them on. So I would sort of take it in that sort of stepwise approach.
On the patients that you decide to go on via ECMO, how quickly do you then immediately proceed with a thrombectomy, or do you let them sort of cool off, so to speak, or what is your protocol?
Yeah, also really important. So I think it depends on when you went on. So I think if you went on ECMO in the middle of the ICU, it is totally okay at that point to wait. I mean, in fact, you really could argue is there really a need to even go right away? Like, why not stabilize them? Check their ABGs, get them sort of sorted out in the ICU, get everything under control, because I don't really think there's a rush to, get the clot out at that point. obviously it makes sense. If you put them on ECMO in the lab, you might as well finish the job. So I think that part's a little bit easier. The one thing I would add though is, if you put them on ECMO, I do feel very strongly that you should go in and get the clot out. I think there is a debate out there in the PE world. Should you just put them on ECMO and do nothing else? Just let them recover. Let the anticoagulation do its thing and wean them off ECMO. And I think you might be successful in a few situations. But, the longer you're on ECMO, the more complications you have. So if you can do something to get them off ECMO faster, do it. So I would say, I wouldn't wait more than a day. I think if you put them on Monday, let's get that thrombectomy on Tuesday. If you crash them onto ECMO at 3 a.m., do you have to take them to the lab and do a risky case in the middle of the night? No, I think you can totally book that case for the next day.
I think that's been our movement. We did a couple of these, ECMO and thrombectomy there, but our tendency has been to get them to the unit, clear their lactate, clear their cardiometabolic stuff, and then bring them back the next day is where we've been trending. Maybe just a question or two from the audience, and then we'll break for lunch. Anybody have anything, or is everybody hungry? Mike?
Continuous lactate.
Oh, wow, I hadn't heard about that. Does anybody know anything?
Interesting.
You can give that talk next year, Mike. That's a cool idea.
It's an interesting topic. It's an interesting topic for sure. Some of the challenges are how do you make sense of all of those dynamic fluctuations. Post-operatively, it has its own issue. A lot of those patients are on pressors. Epi can generate lactate. There's a lot of mitochondrial dysfunction. So what's really driving the lactate production at that point? At our system, we're not doing that yet, but we're doing Q2 lactates on patients that come in with cardiogenic shock physiology to make sure we have a clear direction on how we move those patients. But as far as continuous lactate monitoring, I think it'll be a matter of how are you going to respond and what is defined as a clinically significant change in lactate to make us want to deviate from the strategy that we're currently using.
Well, we'll let everybody break to lunch.